Okay, we can.
So I'm just starting now to start the live stream.
At least let the people to comment. That's right. They can directly, without waiting room. That's right.
We can do that.
Okay. I think by other setting you can do it.
Let me see. Okay, so we are live now, and they're gonna put the link for the YouTube streaming in the chat box so people can share it with others. So I think we can go ahead and start the cards, huh?
Okay. Bismillah ar-Rahman ar-Rahim. Good evening, everybody. On behalf of College of Medicine, University of Anbar, it's my honor to welcome all of you at our today's session. Today, I'm really delighted to invite our distinguished guests from University of Missouri, the speaker, Dr. Amrut Padhye, and the moderator, he's really my friend, my colleague, Dr. Mohammed Al-samarraie. Really, he's my friend since he's been a student in medical college, Baghdad Medical College. Dr. Mohammed, he's the director of pediatric ophthalmology and the adult strabismus in University of Missouri. For Dr. Padhye, I think Dr. Mohammed, he can introduce her and to start our session. Our session related to pediatric specialty and about Messi. Messi is everyone like football, he like Messi, but for the pediatric, he's a problem. Okay, please, Dr. Mohammed, ground for you.
Thank you so much. Thank you so much, Dr. Abdeslam, and thank you all for joining us today. It is my pleasure to be with you for the second time. In this effort, we are trying to keep us all updated with what's going on about COVID-19. I know the audience are of variable backgrounds. Some of them are pediatricians, some are not, but we all share the same concerns, whether we are parents about our children, whether about our patients who get involved with our care. So before going ahead and introduce my special guest today, I want to share with you a couple of resources that I personally find them very useful in staying up to date with all what's related to COVID and your specialty in general. So I'm going to go ahead and share my screen. The first website that I really like is called Doximity. So Doximity is like a social media platform that is specialized, designed for physicians. So basically you go ahead and create your profile, including your current practice and specialty and stuff like that. And Doximity will suggest friends to you based on what you mentioned. Like it will couple you with a specialist in the same field in your area, or other providers within the same institution, or even other graduates from your, a school of medicine or during residency. So we can see there's a bunch of colleagues I have. They're all matched by default by the program. You send them a friend request just like Facebook. What's cool about that is basically it will send you a weekly newsletter by email, including the most up-to-date information about your field. And also there is like a weekly newsletter about COVID up-to-dates, including some op-ed articles and clinical publications. And it will get send you notification about, if one of your friends and colleagues cited in an article or published something. It is more like specific professional social media platform. What's also cool about it, there is a video chat capability that you can conduct a telemedicine contact with your patients without including your cell phone. So you can control like a HIPAA compliant private clinical consultation through video calls. This is the first one. The second option, the second website is called Coursera. Coursera is a very nice and famous website that offers courses for free. So you can basically browse a catalog of different subspecialties in all aspects of like public speaking, language learning, computer design, graphic design, successful presentations. We all been like Zoom fatigue nowadays and bored with all these PowerPoint presentations. I promise you, Dr. Padhye's lecture is will not be boring at all. But getting the skills of getting the successful presentation, you can get courses like this. And what is also cool and important here, you can go and browse public health courses. So if you can, let me show you here. And progress from completed. You can explore based on subjects. So there is health courses. These courses are free, but you can also get paid certificate from institutions like Imperial College or University of Michigan. There is a bunch of courses about COVID-19 treatment and contact tracing. And so these are also available on like phone apps. So you can just browse these courses, free videos on your phone, and get certificates at the end of these courses. Without further ado, I'm going to introduce my distinguished guest today. Dr. Amruta Padhye is Assistant Professor of Pediatric Infectious Disease at the University of Missouri here in Columbia, Missouri, in the United States. She is originally from India, and she did her medical school back in India. Then she traveled to UK when she did her residency in pediatrics, and she achieved the MRCP in child health. Then she moved to the US, where she did her residency in pediatrics and the University of Illinois, followed by Pediatric Infectious Disease Fellowship training at Washington University in St. Louis, one of the well-recognized and distinguished places and children's hospitals in the United States. Then she joined the University of Missouri as an assistant professor and the faculty at infectious disease specialist. And when COVID hit, she was on the top of the frontliners, defeating the virus and educating public and physicians on the same level. We were honored in our local Muslim community in Colombia to have Dr. Padhye twice to educate our public about the spread of the virus and impact on children. And she also participates thoroughly with public appearance on media outlets, and also educating our colleagues and local physicians through the Boone County Medical Society. And we are honored to have her today. Dr. Padhye, one of the things we're going to be asked about, our Iraqi colleagues are concerned about increased spike in the infection of COVID-19 among children. And they're concerned about possible new strain that affect them. That's why you see a lot of interest in this topic recently. Hopefully we get answers about up-to-date treatment and your experience with COVID-19. And we will open the window for Q&A, question and answers at the end of the lecture. So without further ado, Dr. Padhye, welcome to share your screen and start your beautiful presentation.
Okay. All right. Dr. Al-samarraie, you're able to see my screen here, right?
Yep, we see it.
Perfect. So I'll bring it in PowerPoint format. So I want to thank Dr. Alani, University of Anbar, and Dr. Al-samarraie for inviting me here. This is a great opportunity for me to speak to you all overseas and to also learn from you and hear what your experience is out there. So we are right in the heart of United States, right in the heart of Missouri State, and we've had our own share of COVID-19 in children, of course, adults, but children as well, and MISC. My talk is mostly going to be focused on MISC. It's virtually impossible to cover everything about COVID-19 in children, let alone COVID-19 itself. But even in children, there are so many things that could be discussed here today. But I thought I would focus on MISC and then talk a little bit in the end about variants. I know Dr. Taylor Nelson, one of our adult infectious disease colleagues, had in the recent past given you a talk on vaccines. So hopefully that should be well covered so far. So the outline of my talk, I will begin with discussing the evolution of this new diagnosis called as MISC, review what the current case definitions are, the epidemiology of COVID-19 and MISC in children. and then the features, management, compare a little bit about MISC and severe COVID, and in the end, just a brief touch on variants and vaccines. Hopefully that won't be the end won't be very long because there is not much information so far. So again, to begin with, I have no disclosures, no conflicts, sadly. And my disclaimer is that it's really hard to for all of us to keep up with this literature. So as you can see here, Lit COVID is a curated PubMed Medline website, which curates all the literature on COVID-19. And just from a disease that became prevalent in early, starting January of 2020, there is like innumerable, more than 100,000 papers. So it's virtually impossible to be up to date. So I'll try my best to focus on MISC and happy to hear all your thoughts as well. So this MISC, came to be described back in May of 2020 as when, by that time, starting in March, cases of children presenting with an inflammatory condition 4 to 6 weeks after a primary COVID infection started to present. So reports came in from Europe, North America, Asia, Latin America. And what was unique about these kids was that, many of them looked kind of like disease processes that we know that happen in children in the past. So Kawasaki disease, some of them presented like Kawasaki disease shock syndrome. Some of them presented like toxic shock syndrome, so from streptococcal and staphylococcal illness. But again, they shared similar features, but again, they were distinct from these disease processes as well. And then came this terminology. First, in the United Kingdom, they called it PIMS-TS, and then the subsequent name from the US came to be called as MISC. So here is kind of just a glimpse into what was happening back in March of 2020. So on the left side of this, on the y-axis, are the total SARS-CoV-2 cases that were happening at that point in time in the United Kingdom. And on the right side, in a different y-axis, so these are smaller case numbers of MISC. Left side is all COVID cases. You can see this gap of a shift of about 4 to 6 weeks. Once United Kingdom started to see this rise in COVID-19 cases, a few weeks later, these children started to present with a presentation of inflammatory syndrome that eventually came to be known as MISC. A similar thing also happened in the United States. So you can see, in New York, so this is from New York State, they started to see this rise in COVID-19 cases. So on the y-axis, on the left side, and these are in this y-axis, these are cases in pediatric patients, not overall total COVID-19 cases. And as that trend started to go up, a few weeks shifting 4 weeks later, started cases of MISC coming from New York. And on the y-axis on the right side, you can see these individual case counts. So case in point that these cases typically seem to emerge 4 to 6 weeks after an area has seen a peak of their COVID-19 cases in the community. So here is a timeline of recognition and description. So along the same lines, in April, end of April, United Kingdom, so on May 1st, actually, the Royal College of Pediatrics and Child Health in the UK, came up with their case definition of PIMS-TS, followed by in the New York Health Department putting out their alert on May 4th, and subsequently, as you can see, May 14th, CDC put out their case definition, WHO shortly after, and then these are all the big case series of COVID-19 that we have seen emerge. The last of this running case series was from August 7th from the CDC, and then we are now seeing more literature come in. So the existing case definitions of multi-system inflammatory syndrome. So let's focus on this CDC case definition because I'm most familiar with it, but I will kind of also point out the minor differences between the other case definitions. So MISC is described in children less than 21 years of age who present with fevers at least of 1 day. Now, this fever criteria is fairly broad for the CDC definition, while RCPCH has their case definition as persistent fever. The WHO says greater than or equal to 3 days. And so these kids should have fever, and so all kids present with fever and laboratory evidence of inflammation. So that inflammation can be in forms of different kind of inflammatory markers. We will review them shortly. The CDC definition includes hospitalized results. So these are kids hospitalized with fever of at least 1 day, laboratory evidence of inflammation, and involvement of organ systems, at least 2 or more for the CDC definition. And you can see the variations in the others as well. Plus, this is also a diagnosis of exclusion. So something like Kawasaki disease, where we are familiar with that diagnosis, where you have to exclude other disease processes, same thing applies here. So this was the case definition. As we just reviewed the first part, there should be no alternative diagnosis, and these kids should have some evidence of SARS-CoV-2 infection, either being positive by PCR now or in the recent past, or by serology or by a rapid antigen test, or if none of these criteria are met, then at least they should have had some close contact with someone with COVID-19 exposure. Now, this last criteria is a little bit vague, because we see these MIS-C cases happen in situations when there is high community transmission. So it's hard to know if a child has been exposed to COVID when already there's so much COVID going on in the community. Although this has not been much of a problem in the big case series, 99% of the kids either have had PCR or antibody positive. So before we delve into MIS-C cases, let's look at what is going on with COVID-19, because it's important to put COVID-19 infections, acute COVID-19 infections in perspective before looking at the epidemiology of MIS-C. So I like this particular country tracker. There are so many out there. You may have your own favorite ones. Just wanted to share my favorite one. And this is from Financial Times. There is a hyperlink attached as well in this PowerPoint, which I'll share with you all afterwards. But you can kind of pick the countries. You can pick up to 6 countries and look at their trend. So, and you can even choose as in terms of cumulative case counts or new confirmed cases. So what I picked here for this screenshot is one of a 7-day rolling average of new cases per 100,000 population. I think it's very important to have this normalized to a population, because countries with high populations, for example, you can see here how India has seen so many cases in the past, but if you normalize it, then that kind of you're able to compare it with countries with lower population. But as you can see, in the United States, we are kind of now thankfully in that downtrend, although this is always subject to change. And where I come from in India, they've again seen kind of a low plateau for a period of time. And I thought it might also be helpful to include case counts per 100,000 population for Iraq, because I'm talking to you all, and a couple of your neighboring countries as well, to put things in perspective. So having seen this, also wanted to share with you the new deaths. So this is also a 7-day rolling average normalized to 100,000 population for the same countries. Again, to put things in perspective, what we have seen here so far. Okay, and so moving on to just coming to data from the US. How does the US data break down into by age group and deaths into case counts by age group and deaths by age group? Thankfully, pediatrics, so children still account for a very small percentage of number of cases. So on the top here, we have, it tells you how many million cases in the United States, although these numbers can vary from the resource that you use. So close to 30 million, I should say, for United States. The trend, how many people have been vaccinated. Total deaths so far in the United States have been upward of 500,000. And so when you look at the age breakdown, children between 0 and 4 years of age contribute to 2% of cases. Children between 5 to 17 years of age have contributed to 9.6% of cases. So and again, thankfully, the death cases have also been low in children, although any pediatric death is very unfortunate. So 94 pediatric deaths in 0 to 4 years of age in the US, and 197 between 5 and 17 years of age. moving on, what does this mean for hospitalization? So even though we saw that there have been so many pediatric cases, how do they compare with the adult hospitalizations in adults? So in this graph chart, this is again US data for 10 states that contribute to a CDC program called as EIP, which covers about 100 counties in the United States, 10 states. You can see this breakdown of age groups. So this small sliver at the top, which is kind of brown color, reflects the hospitalized proportion of hospitalized pediatric patients, followed by this gray color, which is again a small sliver. So again, among hospitalized patients as well, pediatric patients account for a very small number of proportion of the total number of hospitalized cases. And then the next big age group is our elderly patients, alongside the next middle age, and then the young population as well. So this is a kind of a summary of findings from our from our American Academy of Pediatrics. So every month they put out some of the statistics. So they reported as of this month, as of early this month, they reported about a rate of 4,000 cases per 100,000 children. So in the prior graphs, that was a proportion of all population, but this is kind of a better understanding of the rate of amongst 100,000 children, how many pediatric cases do we have? 1.3 to 3% of total reported hospitalizations were in children. So you saw that that's similar to the previous graph, and between 0.1 and 2.2% of all child COVID-19 cases resulted in hospitalization. So that's even a small proportion of all pediatric cases end up in the hospital. Again, thankfully, as I reflected before, mortality is low in pediatric patients. So coming to MISC, so now that I've given you an overview of COVID-19 in the US, what are we seeing here with our cases of MISC? So far to date, there have been, as of March 1, the CDC, so all cases of MISC are meant to be reported to the state health departments, which feeds information to the Center for Disease Control, CDC. However, this reporting is voluntary, so there may be some delay in reporting, some, it again depends on each hospital system, but I think everyone is pretty, most hospitals have a good infection control program where one of the, or this is what happens with us, one of our infection control nurses will report the case count to the state along with many other reportable conditions. So there have been about 2,617 cases so far reported since the start of description of MISC. Sadly, 33 patients died because of MISC that we know of, and the median age group is somewhere between, the median age group is 9. So this middle chart, so that's most patients present in that age group. Sadly, again, even in the in the United States, as we all know, just like how COVID-19 has disproportionately affected our Hispanic, Latino, and Black populations, we have seen that same phenomenon even in MISC cases as well. So this far left is our Hispanic communities, and then followed by the Black non-Hispanic population. So just a summary of all the cases that have been reported so far. Median age is 9 years, a little more weight towards male patients, and like I mentioned before, 2/3 of the cases are in Hispanic and Black Americans. 99% of these patients, like I mentioned before, have had either a PCR or antibody or an antigen test positive for COVID-19. And the remaining 1%, sorry, I forgot to finish that sentence. Remaining 1% are those who may have just a history of exposure, but probably either didn't get a test or tested negative. So this is a breakdown of the US cases. So let me just show you where we are. This state right in the middle here is Missouri. Right in the heart of Missouri, right in the middle is Columbia, where I am from, where Dr. Al-samarraie is from. And our two neighboring states, I hope you're able to see my cursor as I'm showing it. And so on this side is one of the big cities that we have, which is a referral hospital for us. That's called St. Louis. right here on this end. And on this end is another big city called Kansas City, which is our another big referral hospital for us. Okay, so even though here it colors off as 1 to 24 cases, we know that locally in my center we've had at least 12 cases of MIS-C and higher cases both in the bigger cities. So this number again, the 2,617, is probably not accurate. So this is kind of just gives an idea of what we have seen. So the initial, as I mentioned to you, how the number of COVID-19 cases. So let's follow this graph. So in dark blue are our daily moving average of number of MIS-C cases. So as you can see, as the months, so and this dotted line is that of COVID-19, daily COVID-19 cases with this y-axis on the far right side. So as you can see here, the number of cases of MIS-C were higher. Of course, this y-axis is a different count, so it's difficult to compare that peak. But you can see when the COVID-19 cases peaked, we saw a peak in MIS-C. This was April, May in New York City. And then our experience here locally, we had our peak of MIS-C a peak of COVID-19 in my community in September, starting late September, and that's when we started seeing our first patient in mid-October around this time. Again, like I said, this data is not complete yet. So what are the common signs and symptoms of MIS-C? So all of these children are going to be presenting with fevers. So every child who has had fever, in my experience and what we have read so far, these kids may have fevers as little as for 3 days and continue to have fevers for a longer period of time. Sometimes it takes a week before anybody thinks about MIS-C as a differential. Although with more awareness now in our community, we are able to we are screening these kids or evaluating these kids for MIS-C much earlier than when we started before. So these kids are going to have fevers. They may have evidence of organ dysfunction or shock. So some of these kids will present like Kawasaki disease. So Kawasaki disease, as you know, is this multi-inflammatory disease process that happens typically in young kids, so younger than 5 years of age, and they present with signs of inflammation in their body. So in the eyes, tongue, extremities, and the complication there is that in addition to inflammation in these areas, they can also have inflammation of their coronary arteries, and which is the biggest concern in these Kawasaki disease patients, that we want to prevent that coronary artery enlargement or an aneurysms that can put them at risk for cardiac problems going forward. So in addition to Kawasaki disease-like features, some of these kids are different. These kids with MIS-C are different in that when Kawasaki disease typically presents in the younger kids, less than 5, these kids with MIS-C are typically a broader age range and slightly older, so the median age of 9 years, like I mentioned. And they may present with more gastrointestinal symptoms. So most of these kids that I have seen have had abdominal pain, diarrhea is a main feature. They have had headaches as well. Some of them present like shock, like streptococcal or staphylococcal toxic shock syndrome, but actually they don't have that, but they have MIS-C. And then some of these with ongoing inflammation can have features of cytokine storm as well. And in these kids, if they have shortness of breath, then it's more probably, rather than actual pneumonia, COVID-19 pneumonia, although there can be an overlap as well, these kids may have shortness of breath, probably from congestive heart failure. So a nice infographic that puts this all together. So like I mentioned to you, all in the salmon colored box over here, all these mucocutaneous findings. Then, CNS symptoms. These are the two predominant categories, and abdominal symptoms, along with cardiac findings. So they can have myocarditis, coronary aneurysms can develop early or later on. We still don't know what is the exact timeline of development. We'll talk a little bit more about coronary aneurysms. And some of them may have concurrent COVID-19 pneumonia sometimes, but typically that shortness of breath is from ventricular dysfunction. Some of the hematological abnormalities we see in these kids, they have elevated neutrophil count and lymphopenia, so low absolute lymphocyte count, and other organ system involvement as well. Okay. So just one slide on pathophysiology. There is so much to talk about, but just kind of a brief is that even though we think of like Kawasaki disease, acute COVID-19, MISC, and there are some overlap of symptoms between these three, immunologically, we think that, I think it is now felt that the hyperinflammation that is seen in MISC has a different pathway compared to that from acute COVID-19. And in one of this very nice paper from Cell, they talk about how T cell subsets can discriminate Kawasaki disease patients from MISC. Again, this is a whole new area of science and which is rapidly evolving. So with regards to organ system, as clinicians, what is important to us? What's important to us is that what are the organ systems? So really a wide array. So this even though there are many of the this slide has many symptoms involved, I want you to focus on the organ system. So, and this is kind of a summary of some of the bigger case series. So approximately 90+% of kids with GI symptoms. This can be really variable: diarrhea, abdominal pain. Some have been diagnosed as appendicitis by mistake, or some who may even present with appendicitis in the setting of MISC. We see mesenteric adenitis fairly often when imaging is performed. Cardiovascular, they can present as shock, low blood pressure, or congestive heart failure. They can have myocarditis, all of these cardiac coronary aneurysms, pericardial effusion. Some of the in our experience here and in many of the some of the papers that I've read, trivial or mild mitral regurgitation is seen fairly often, is a fairly common cardiac finding in these patients. And then skin findings are again very innumerable: hematological parameters including lymphopenia, elevated D dimers, low platelets, all of these. So I'm not going to go into more detail into these because these slides will be available to you afterwards. But just to kind of throw light on some of the common lab findings, you often will see these children have elevated ESR, CRP, ferritin, LDH. Their lymphocyte counts may be lower than 1,000. So typically we say in young kids, normal lymphocyte count should be at least 1,500, absolute lymphocyte at least 1,500 or above. They can have low platelets, neutrophilia, elevated BNP, hyponatremia, and elevated D dimer as a marker of inflammation. So from this case series of 570 patients reported in MMWR, one of the literature where CDC publishes some of their literature, more than upward of 60% of the kids had at least 4 to 5 systems involved. And like I mentioned before, gastrointestinal and cardiac symptoms, cardiovascular involvement was most common. 2/3 of these kids requiring ICU admission. Mortality rate, case fatality rate was about 1.8%. And these numbers, I mentioned to you, 33 out of the 2,600 cases is the current case fatality. And I'm going to kind of move on. And they, in this paper, they try to divide their patients based on this statistical modeling technique called latent class analysis, and kind of were able to separate their 570 patients into 3 classes. So this one class, one group of presentations present more like, they have a lot of organ system involvement, and they don't seem to have any overlap with Kawasaki disease or acute COVID. So these are the kids who present with significant abdominal symptoms and shock or myocarditis. The second group is the one that had some overlap with acute COVID-19. And this third group had an overlap more with, this third group was the most that looked like atypical Kawasaki disease than anybody else. So what is the role of an infectious disease doctor in these situations? So my role as an ID doctor is to kind of tease out what features of this any particular case is more of a actual infectious disease rather than a multi-system inflammatory syndrome. I have to say that in the last few months, most of our sick patients have ended up having MISC, but we have had kids present with prolonged fevers with, let me think about a few, like some who have been diagnosed with classic Kawasaki disease, some who have been diagnosed with herpes simplex mucositis who presented with fever, some with some tick-borne infections that we see in our community. So it is important not to go down this track of just thinking everyone has MIS-C and missing out other treatable infectious causes. So the differential diagnosis is very varied. They can present, we know that viral infections like EBV, like adenovirus, can present in a similar fashion with prolonged fevers as well. So this is just kind of a list of all the things that I'm thinking about. One of the biggest mimic has also been gastroenteritis. So for some of our first few cases had shown up either in our ER or in another hospital ER. In the first few days, they would get their test for COVID-19 PCR from a nasopharyngeal swab. They would be negative. And so they would go home thinking that they are dehydrated from diarrhea, only to come back second time, third time, and then be admitted, and then, have this diagnosis of MIS-C. Now we're recognizing these kids early on, but gastroenteritis, viral or bacterial, was one of the most common differential that I was thinking of as well in the beginning. So there are many guidelines out there, but as this is a new diagnosis, it is hard to have any very highly evidence-backed approach. But again, we know how to recognize kids with Kawasaki disease. We know how to evaluate those, and that's kind of where both the evaluation and management for MIS-C has evolved as well. So this is just one of the frameworks that the American College of Rheumatology has suggested. So even when you think of clinical symptoms of fever, child presenting with fever, a link to COVID-2, and any two clinical features, then you have to start thinking about, do they have shock or no shock? As in, are they very sick kids? Or can we do this approach on admission, but in a really systematic manner? If they're very sick, then they need to go to the ICU, and we start all our lab evaluation in parallel. But if they're kind of stable, then we can do our labs in succession. So you'll find that many hospital systems, some of the things that even before we had a consensus in my hospital on how we would approach these patients, we were looking at how bigger centers in the US were approaching these patients. So you will find easily available with a Google search. You'll be able to find guidelines from just a couple of the hospitals that I used to follow, but there are many other centers that have similar kind of guidance as well. So let me just take you through a simple approach for these patients. So like I said before, we want to know how sick this child is. So if it begins with initially deciding, does the child have any of the following the same things that I mentioned: fever, a link to COVID-2 and SARS-CoV-2, and at least 2 organ systems. And then if that's a yes, then you look at, do they have signs of shock? So if that's the case, then you're going to admit to the ICU directly and get blood cultures, start them on antibiotics, and do the rest of the evaluation alongside. So we call this tier 1 and tier 2. Many other centers call it in a similar or different way, but basically it is looking for signs of inflammation and any of the other parameters that we're looking at. So while in this process, if we identify an alternate etiology, then you treat that etiology. But if you haven't, then we encourage our admitting teams to quickly admit them, to quickly consult all these services involved. So a cardiologist, rheumatologist, infectious disease doctor. And so if these kids have had fever, are not in shock, then we do the evaluation in a stepwise manner. And if we don't find any etiology, then we do the step 2 evaluation. Typically, this involves doing an echocardiogram, an EKG, and admit to the inpatient non-ICU floor. And of course, also involve the same specialist so that we can have a multidisciplinary approach. If none of these criteria are met, but if you feel like the patient is not ready to be discharged, then again, of course, kind of revisit that thought process of whether we need to evaluate for MIS-C. I see that there are a few questions here. Okay, there's nothing ongoing. Perfect. Okay. So the treatment approach, again, depends on how sick this child is or what kind of organ-threatening disease they have. And the definition of organ-threatening disease is a little bit vague, but we usually ask our rheumatologist as well. So as first line, just like in Kawasaki disease, we are treating the kids with IVIG. If they have refractory disease, and that is determined again by a rheumatologist, or if they have persistent fevers, or if they change clinically, then we add in steroids. Steroid dosing can be either on the low to moderate dose, which is 1 to 2 mg per kilo per day, or high dose, which is in the range of 10 to 30 mg per kilo per day. And in some situations, we have used Anakindra. Just to kind of share with you some of our experience here, we've had like about 12 cases so far. 11 of our patients, we gave IVIG. One patient, by the time the child was admitted, her fever settled, the patient's fever settled down, was clinically doing much better. So we actually didn't do any treatment, but the child did meet the criteria, CDC criteria. 11 of our children got IVIG, 7 of our children got Anakindra. So that just, many of these kids even got steroids as well. 7 kids got steroids in the low or high dose format, and 4 kids got Anakindra. So it's kind of a very variable presentation for all these, and it depends on how the child presents. So why are we so concerned about these kids? In addition to having inflammation, multi-system inflammation, it's also important to know that one of the main concerns, again, is the cardiac manifestation. These kids can present with ventricular dysfunction, coronary dilatation, and aneurysms, and kind of the pathophysiology that's reflected on the left side, just like children or adults with COVID-19 have COVID-19 has major impact on kind of their on thromboembolic phenomenon, etc. Here as well, because of this dysregulated inflammatory process, there can be endothelial injury and hypercoagulability as well in these patients. In this series, this was a publication from Circulation from November, where they reported in a series of patients presenting with MISC, 50 to 80% of them were presenting in shock. 22 to 64% had met either criteria for complete or incomplete Kawasaki disease. And what is striking is that up to 2/3, up to 3/4 of, anywhere from half to 3/4 of patients had evidence of left ventricular dysfunction, either by echocardiogram or elevated BNP. Some of the recommendations for cardiac testing are again streamlined for each specialty. So cardiologists recommend a certain kind of follow through for these patients on frequency of monitoring of EKGs, monitoring of echoes and lab parameters, including BNP and troponin. So these kids, they do need follow-up, with all these specialties. We once are, the median hospitalization that we have seen is anywhere from up to kind of, I should say, in a range of anywhere from 3 to 12 days in the hospital. And these patients, after they're discharged from the hospital, we want them to see their primary providers, so their pediatrician, family doctor, anybody in the community who can check on them in 2 to 3 days. And they come back for close outpatient follow-up with rheumatology if they're being managed with immunomodulation. These kids get started on steroids, and typically if they get started on steroids, they go through a taper of steroids. Anakindra is also tapered over time. For echocardiograms, they get evaluation of cardiac function, valvular function, pericardial effusion, and coronary artery dimensions. And these are done in the outpatient setting fairly frequently. So initially at 2 weeks, then at 4 to 6 weeks. And if anything's abnormal, maybe more frequent monitoring. Any additional outpatient will depend on who were involved in the hospital. So the other services that we have involved, of course, have been hematology. When we have certain select criteria for which kids are going to need prophylactic anticoagulation, which kids are going to need therapeutic anticoagulation. We had a child present with an MCA stroke in the setting of MISC and underwent thrombectomy and had a very good outcome from that. In that patient's care, there was hematology. In addition to the 3 services that I mentioned, there was involvement of hematologist, neurologist, and physical medicine, rehabilitation service as well. So just to summarize the management, and I wanted to just throw light on a couple features. So these kids who present with like shock, they may look like they have septic shock. So typically, if a child coming to the ER having diarrhea, having low blood pressures, the initial thought is to hydrate, right? With volume hydrate with a lot of fluid resuscitation. But these kids, if you did generous fluid resuscitation, that can be really detrimental to their outcome, because that can tip them over into congestive heart failure. So our management plan involves that if the child has lowish blood pressures, they can get one bolus of fluids, so a 20 ml per kilo bolus. But if the admitting or the ER or the admitting team, they think that they need more than one bolus, then that is the time you're going to have to call the cardiologist or the ICU, just to make sure that everything's okay before continuing to administer boluses. So like I again mentioned to you, multidisciplinary care is important in these patients. We repeat their lab parameters on a very regular basis. So like I mentioned, every hospital system has adopted their own way of frequency of lab monitoring. I have to say that we think maybe we are doing more labs than are actually needed, but it's hard to know in a disease process that is so new. It's hard to know, which are the key factors that need to be monitored. And then antibiotics we only use if there is concern for sepsis. As soon as it becomes very obvious, maybe in that first day or the second day, that the child with shock does not have bacterial sepsis, we stop the antibiotics right away. Antivirals, typically there is no role for Rembessover in these patients. Occasionally, or it may be in the first case or so when they tested positive by PCR, and there was a question of whether they had some respiratory involvement, we did start one of our patients on Rembessover, but in our subsequent patients, we have not done that when it has been fairly clear that this was MISC and the respiratory symptoms are coming from signs of congestive heart failure. We talked a little bit on immunomodulatory management. I think this slide got repeated, sorry. So these are just a couple new papers that came out. Pretty much one of these is from like March 9th, so literally a couple of days ago. This paper looked at factors linked to severe outcomes in MISC in the US. So of 1,080 children that were reported to the CDC when they did a retrospective chart review, they realized that, or I guess the key things to take home are that ICU admission is more likely in the child who is 6 to 12 years of age. It's more likely in Black patients compared to white. Patients presenting with shortness of breath, abdominal pain are more likely to be in the ICU. And those who had high CRPs, troponin, ferritin, D-dimer, BNPs, IL-6, low platelets or absolute lymphocyte count, they were associated with more likelihood of being admitted to the ICU. A similar association was also seen for those presenting with decreased cardiac function, shock, and myocarditis. Also, they found that coronary artery abnormalities were more common in male patients and those presenting with mucocutaneous and conjunctival injection. So like those who present similar to Kawasaki disease have more coronary artery involvement more than the others. So this is just kind of a forest plot of all of their odds ratios, but kind of it summarizes the same things that I just mentioned. So I'm going to, in interest of time, we'll skip through these couple. And then in this case series, again, so this is a different paper that looked at, this was also published just recently on the 24th of February, that looked at 1,616 patients from 31 states in the US and compared the characteristics and outcomes of these children presenting with MISC with those presenting with severe acute COVID infection. And what was different among these two categories? So the kids presenting with MISC were more likely than those presenting with severe COVID to be in the age group, again, of 6 to 12 years of age. So you can see here, to the right side of this line, and they were more likely likely to be Black children in compared to those presenting with severe COVID-19. And a similar breakdown for comparison of these two patients, so children presenting with MISC and those presenting with severe acute COVID-19 infection. So the ones with MISC were seen to have more severe cardiovascular or mucocutaneous involvement than those with severe acute COVID. So know that acute COVID can also have skin involvement. Acute COVID also has cardiovascular involvement like myocarditis, but the ones with MISC are more likely to have these organ systems involved than those presenting with severe acute COVID. Again, just an understanding of at least 3/4 of patients presenting with MISC were admitted to the ICU, whereas only about 43% of children presenting with MISC were admitted to the ICU. There were 10 in this series of over 1,000 patients. There were 10 deaths due to MISC and 8 children with severe acute COVID who died during their hospitalization. Now, in the same paper, they also broke down those kids who had, with MISC, who had reduced LV dysfunction. So 34% of patients presenting, so up to 1/3 of patients presenting with acute MISC had reduced LV systolic dysfunction, and about 13% of patients with MISC had coronary artery aneurysm. This in comparison to Kawasaki disease, when we talk about Kawasaki disease and coronary aneurysm incidence, historically we knew that coronary artery aneurysms in Kawasaki disease happen in 25% of patients who are not treated with IVIG. And by treatment with IVIG, we are able to bring that incidence of aneurysm down to 4%. So that number, we don't know. We don't know yet if treatment with IVIG, with steroids, what impact does it have on incidence of coronary artery aneurysm? Time will tell. So what happens to these kids with low systolic dysfunction? How do they do over time? So about they do very well. So 90% of systolic dysfunction is normalized. 90% of patients with systolic dysfunction, it gets normalized within 30 days. And again, 80% of patients with in 80% of cases of patients with coronary artery aneurysm, the coronary changes become normal within 30 days. So that's good, thankfully. So just as a summary of things to think about in MISC, I think having it high on your radar is very important. So any child presenting with persistent fever for more than 3 days without any other source of infection or source for fever should be evaluated for MISC. So typically with viral gastroenteritis, you have vomiting, fever, diarrhea. The fever and vomiting in these cases, in typical cases of viral gastroenteritis, they resolve within 1 to 3 days. However, in MISC, that does not happen. The fever continues, the GI symptoms continue. Again, any child presenting with low blood pressure, shock in this time and age should be evaluated for MISC, or those who are moderately or severely ill, where you don't know what is going on with them. And also when a child has a known history of even symptomatic or asymptomatic COVID-19 infection, we have to think about how do these children if these children go on in a few weeks or month to 2 months, go on to have fevers, and they should be evaluated or at least thought about MISC. I have to say that our longest experience with the interval between definite COVID-19 and with MISC was, the longest interval was 8 weeks, but most of the children that I've seen have been in the reported age range of weeks of 4 to 6 weeks. So I think this is a good summary of MISC. I only am going to spend a few minutes on a few more topics here. So just to give you an highlight on acute COVID-19 treatment in children, as of now in the US, we are the only available, that is FDA approved drug for COVID-19 in children, that too for those 12 and above for acute infection, is Rembessover. Those less than 12 years of age, Rembessover is available by emergency use authorization. And I like to go to, because there's so much literature, it's hard to keep up with everything. I like this resource that we use here. It's the Nih Treatment Guidelines, where it breaks down all treatment modalities and along with the evidence and what's current. So I like to go to this intermittently. But the section on COVID-19 in children from this website is extremely limited. So basically it says Remdesivir can be used, but there is not sufficient data for any of the other treatments. So management should depend on what complications the child has, what is the severity of disease, and if you do give any unapproved or drugs that have emergency use authorization, what is the potential for drug toxicity and drug interaction? So the management is fairly case-to-case basis. Again, there are many of the bigger hospital websites that you can approach, but typically for acute COVID-19, it's management of the respiratory illness, with supporting the respiratory status, Remdesivir if it can be given in select situations, and dexamethasone. Again, the data is not there for pediatrics, but we extrapolate and use dexamethasone in children who have severe acute COVID, just like it has been in the adults based on the adult data that's available. Just a very brief on the emerging variants. So what are we seeing in the US? So far reported cases, again, the B117, so this is the UK variant, B1351 is the South Africa variant, P1 is the Brazilian variant. So there have been, again, we have only, the United Kingdom had such a real good surveillance system for screening for these variants. Things are now currently in place in the US, and so the number of reported cases are kind of being recognized. So this is where we are in Missouri. So far, not reported number of cases as of March 9th are only in the range of 100 to 200 patients, likely more than what is actually identified so far. So just a brief summary of what we know about these variants. We know that they are more transmissible than the original known strains. And that can, because of that, that can lead to more number of cases of COVID-19. And that can potentially put a strain on the healthcare, on all healthcare resources. But so far, what do we know about vaccinations? At least in the US, the vaccines that we're using so far have been, there have been effective, or we think they're going to be effective for the B117 strain, although there is different data for the South African variant and the vaccine that was in use over there. What about children and variants? So we know that B117 is more transmissible variant overall, both in adults and in children, but it's nothing different compared to children than from the adults. So that is where I'm going to kind of leave this at with discussing about the variants. But the bottom line is that no matter how many, no matter what variants, the mitigation strategies are going to be very important. So it's important to vaccination of our communities, continuing to maintain the other mitigation strategies that were available before vaccination. So use of masks, hand hygiene, physical distancing, although now CDC has allowed in the US, vaccinated individuals to be around those who are vaccinated and mingle with those other people who are vaccinated, and those who are vaccinated to also mingle with unvaccinated people from one household. But if there is more than one household contact, then that using masks is very important. Again, importance of we have to continue to quarantine and isolate cases as they become identified. I love this Swiss cheese a model for COVID-19. The Swiss cheese model has been typically used in safety, in the hospitals, quality safety initiatives. But here is the model for COVID-19. So many other, each of these strategies allows or prevents that transmission of that virus through all of these holes. And one of the most recent strategies is vaccination. So just to see where the world is going with vaccines, again, the Financial Times has a COVID vaccine tracker. I'm sure there are other vaccine trackers out there. So far, I think from what I read in the last few days, the number of fully vaccinated people in the US has surpassed the number of COVID-19 diagnoses. So 31 million people have been at least fully vaccinated with 2 doses. Here, this is a cumulative count of number of doses, not necessarily fully vaccinated. So, again, you can select the number of countries, and I did not find any data on vaccination numbers that are fed into this website from Iraq, and hopefully you can also throw light on that to me. This is a great vaccine tracker that I like because it kind of curates all the number of vaccines that are in use and gives you some good information on individual vaccines as well. So as you can see, so far 6 vaccines are in early or limited use. 6 vaccines have been approved for full use, and 4 vaccine trials have been abandoned. But this is amazing, the number of vaccines that have gone through this pipeline. Some of the leading vaccines, as you can see, that website has NY Times. I think you have to log in, create a login, but it's free access, and you can look at all of this data. Every individual vaccine has basic information provided to it. So if you click on the Pfizer vaccine, you have more information. I was told that the Sinopharm is the vaccine that's available to you in Iraq, and so again, I just pulled in some of the information. So this is your inactivated vaccine. And actually on December 30th, the Chinese government had reported that the vaccine efficacy was pretty good at 80%. But the detailed results of their phase 3 trial apparently have not yet been published. At least that was the updated information. I didn't fact check it further over here. So currently, the Sinopharm vaccine has been used in all these countries, and this individual level data is available from NY Times for all of the other vaccines. And you can also go into this. There is a section here, a hyperlink to how the vaccine works. So again, it gives you more details. Honestly, you don't even have to be a medical professional to be able to navigate these vaccines. As long as you can navigate the internet, it's all broken down into very simple terminologies. So I think as the hour has run up, I'm going to kind of stop there and see. I would really like to know about your experience there, if anybody is willing to speak or share, so I can learn as well. Regarding vaccination in children, so that has been just yesterday, or maybe in the last few days, Dr. Fauci said that, people have to kind of push for vaccine development and vaccine trials in children. Currently, I know that, the Pfizer vaccine trials were ongoing for 12 to 16-year-olds, and Moderna vaccine trial, Moderna is kind of also kind of working on their trials in children. So hopefully, I think I vaguely remember Dr. Fauci also say that the hope is that by late fall, at least in the US, we may have vaccines available for the older children. But let's see. I'm very hopeful, and I think it would be great. One of the questions that comes up is, what about MISC and vaccines? Will vaccination prevent development of MISC? I think that makes sense, because if you don't get COVID-19, then you won't get MISC. Some questions have come up whether we should vaccinate kids who have had MISC. Is it safe to vaccinate them? I don't think we know anything to say one way or the other. So I will defer on that question that I myself proposed. So I think that's all that I had to share here. I see a question on ivermectin. There have been no trials that I know of in children, and therefore whatever has been published in adults. And from what I understand with ivermectin, even that has been kind of the recent trial that was published in adults for outpatient use that didn't make any difference. So that has not been something that we have used in the US, at least in hospitalized patients. And from what I understand, even in adults, we don't use it here. So that was my thought on the ivermectin. I'm happy to take any other questions. Oh, role of aspirin, that's amazing. Yes, sorry, I didn't mention aspirin. We do start these kids with MISC on aspirin as well, but not with the Kawasaki type dosing of, Kawasaki has 2 different dosings, 30 to 50 mg per kilo per day in that acute inflammatory phase, or 80 to 100 mg per kilo per day. In our MISC patients, we have been using the low end dosing, so 3 to 5 mg per kilo per day, and max, we cap it off at 81 milligrams. So that's a part of our treatment algorithm as well. I'm happy to share that with you all, what we use here. again, we don't know what the impact that this has on the outcome of MISC. Time will tell. And with regards to low molecular weight heparin, so we are both our prophylactic and therapeutic anticoagulation option has been Lovenox, so that's your enoxaparin, and we have certain criteria where we would use it in our in patients prophylactically and therapeutically as well. Again, I don't know how much of impact that has on the outcomes of these patients. Only time will tell. With regards to the new variant presentation in children and its virulence, I think I just briefly covered that topic. Again, time will tell. More of that literature is coming from UK because they saw most incidents of the new variant. But again, you know, as data is available, we will know more about this. I'm going to see back. Is there any comparative trials for using IVIG and steroids versus Rembessover alone? So that's a good question. Actually, I didn't bring up this one particular retrospective observational study that was published last month, I think, and that was on seeing if the kids with treated with MISC, they compared treatment with IVIG alone and IVIG with steroids, and there, again, you know, with limitations of a retrospective observational study, the impression or the conclusion was that probably it might be beneficial to give both IVIG and steroids upfront initially rather than start in a stepwise fashion with regards to resolution of fever. But again, you know, that study has limitations. Since that paper, we kind of have decided that our patients who get admitted to the ICU, we would definitely, even if they don't have shock or evidence of end organ disease, but that we would start them on both IVIG and steroids. There has been no trials on IVIG and steroids versus Rembessover alone. I think we know that Rembessover, has its own different role, and MISC with the pathophysiology being completely different. I don't think there may even be any trial that compares these two, because we know that these kids with hyperinflammation do need some kind of immunomodulation, and doing it with Rembessover alone is not going to tackle the immunomodulatory aspect. Did I miss any other questions, Dr. Al-samarraie?
Thank you so much. I was tracking the questions too. I'm glad that you picked them up. Thank you so much for the great presentation, Dr. Padhye. Really, this very helpful, coverage of up-to-dates. And I encourage everyone, to ask questions in the chat box. We'll take them accordingly. And I also encourage any pediatric specialist in the audience to feel free to raise a hand and tell us a little bit about the Iraqi experience in dealing with children with COVID. I only recognize Dr. Bassem Attallah, my ex-mentor in Fallujah Hospital, as pediatrics among the audience, but whoever, feel free to just raise the hand and tell us briefly about your experience and how the new strain, or presumably the new strain in Iraq, is affecting your practice and your experience with children. While waiting for more questions, I wrote down a couple of them.
Sorry, Dr. Mohanna. I think one of the questions from Dr. Bassem Attallah, but it looks sent to me directly by mistake, possibly. The role of enoxaparin and the proper dose in children.
So with regards to the dosing of enoxaparin, again, like I told you, this has been such a multidisciplinary approach. When we came up with our guidance, I sought the help of our intensivists and our, to kind of scour through the literature. So I can share with you what we have been following. I don't have the source literature, but I can tell you that there is not a lot of evidence into saying a certain dose is better than the other. I don't have the dosing at the top of my mind, but I will definitely share what we have been following here with you all.
Thank you so much.
Dr. Madhye, they asked if it's possible to share the PDF for this presentation.
Absolutely.
Okay. It's up to you.
Oh, yeah, absolutely.
Thank you.
Dr. Padhye, so you report like the CDC, analysis up to July 2020. And I am pretty curious about what happened after then, because the school started in August. And I would assume that there's a lot of increase in number of COVID among children after school reopening. I know this is a far away from the political perspective of the school debate. I know you've been very, a strong heart mom to send your two kids to in-person school since the start, and you had good experience so far. But generally speaking, how did the going back to school affect our curves in children, COVID in children?
Yeah, so, there is some really good new data coming from some of the, I think, North Carolina, I can't remember which states, but the current consensus is that after the schools have started recently, there has not been any increased kind of incidence in schools. Again, the CDC has put out some good papers on whenever there have been school outbreaks, there have usually been cases that were caught in the community and related to either adults in the school. So now I think most schools are moving towards being open, because we have seen, we have seen such an impact of being out of school on our kids so much. So not just loss of education as well, but all the social aspects. Schools provide free lunches for these kids. They're not able to get that. They don't, the incidence of mental health in adolescents has also gone up a lot. I have to say, sadly, that we've seen increasing hospital admissions also for mental health issues in children. So I think it has to be the fact that, yes, it's simple to say let's keep kids out of school, but there are so many other unforeseen side of problems that we've seen from being out of school. So I've been very passionate about, in the right situation, that the kids need to go back to school. And now that in the US we have seen a decrease in our community incidence of COVID, I think there cannot be any better time to send them. Dr. Al-samarraie did rightly say, my kids have been in school. Fortunately, I've been able to send them to a private school, and our private school was comfortable with opening early in September, keeping all our mitigation strategies in place. But that was not possible for many of the public schools. But now that the community incidence has dropped, this cannot be a better time for them to go back to school. Again, the other thing is, we have seen these kids with MISC. They have mostly, when we hear about when we hear about when they had their symptomatic or mildly symptomatic infection, these were not kids who were getting it from school. There were some schools in our smaller cities surrounding Columbia that were open, and they were getting it from the community, from family members. So I think, it's time that we allow kids to be in school. Yeah. And definitely, I'm not saying that we should not have those strategies in place. There should be mask wearing, and kids are such great mask wearers compared to adults. So mask wearing, hand washing, hand hygiene, not allowing sick people to come to school, even if it seems just like a viral illness.
I'm telling you experience from, I know my family and friends in Iraq. We have this issue of still in the state of denial. So many patients who come to you with obvious COVID symptoms, they try to deny that they've been exposed, or they try to hide away from the fact that it was COVID. They're just like, oh, common cold. I was sleeping under the air condition, after a hot day or something like that. So how is important the history of exposure to COVID when we have such a vague, community awareness about bringing the symptoms up in children? When you diagnose kids with like MIC, and then you want to dig in history with COVID exposure, and you face this strong denial between the family, especially if like remote, how that's crucial in your diagnosis and workup.
So with regards to exposure and MISC diagnosis, we have, like I said, all our patients here whom I've seen have had an antibody that is positive. So it becomes and not all of them, many of them, like I think only 4 or 5 patients of the 12 that I've seen had any known symptomatic disease. But then when we say, okay, this could be MISC, the antibody is positive, and then the family starts to remember, oh, somebody had just a mild cold, but those symptoms went away, or someone in the family. So I think in the end, for diagnosis of MISC, it doesn't matter very much. You can do the antibodies, they're going to be positive, and then the diagnosis becomes pretty obvious. So we don't heavily rely on that history. Also remember that when community transmission is high, it's very hard to know. Now that the cases of MISC are decreasing, we are seeing other viruses that we typically see in this age group. So we are now seeing rhinoviruses, we're seeing other coronaviruses that were there before, we're seeing adenovirus in the community. And that only tells us that probably COVID-19 is not circulating, and now we are kind of picking up all of these other viruses. With regards to the denial, I think that the denial, it's sad, but there is also this stigma that was attached, right? With I have COVID-19, and then people are going to shun me. I'm going to get isolated. I've heard about, situations, from my family who lives in India, about how they would, put a sign outside the building. But those measures are also important for public health and for infection control in the community. But yes, there is that stigma attached. So it is a sad reality. That's all I can say.
Yep. How important is the respiratory symptoms among children with COVID? I saw some reports from Iraq, some kids with very bad CT scan findings, and the classic adult, involvement of the alveolar system. How that is significant in your experience among children?
So the kids who have ended up in the hospital with COVID-19 because of their COVID-19. So we have had kids because during the peak community incidents, or even now, we have still been screening any child who gets admitted, any adult or child who gets admitted to the hospital gets a COVID-19 swab, whether they have symptoms or not. And that's so that we can properly, assign rooms to them. So we've had kids being admitted who were asymptomatic COVID-19 with other problems. But those kids who were admitted for COVID-19, typically they have been kids with underlying medical conditions or high risk factors, one of them highly being obesity and the other with underlying respiratory conditions. And there are many others that are, a list of many other high risk conditions that we know of. So we don't routinely do CT scans on these kids. Only if doing a CT scan changes the way we manage the patient, then we do the scan. If they have respiratory distress, we support their respiratory status with whichever modality they require. Hopefully that answers the question.
Sure. Is there any specific risk factors among children who get COVID, like it predicts who is going to end up with MIC?
With MISC, actually, so the risk factors that we've seen in COVID-19, like underlying medical conditions with obesity, they have not really panned out in as such in MISC. And so I think it's again hard. We don't know yet which are the kids who are more at risk of getting MISC. Although, like I showed, we know that the age group there is a particular age group for MISC presentation. Black and Hispanic kids are more likely to get are more often represented in that cohort, but we don't know exactly which kid is going to go on to develop MISC and which isn't. We just don't know yet.
Yes.
A question on, are you using Remdesivir widely in children with COVID-19? So we are using Remdesivir if they need any supplemental oxygen, or they are admitted or additional respiratory support more than just supplemental oxygen. So those are the kids where we are using Remdesivir in acute COVID-19. We are using dexamethasone in children with who are admitted with severe COVID-19. So severe COVID-19, I think, is defined as anyone who needs more than supplemental oxygen. So any kind of respiratory support. So we're using dexamethasone in those kids. I think the data, like in the adults, the understanding is that once they're mechanically ventilated and have severe illness, Remdesivir probably doesn't matter, and that's where dexamethasone plays a bigger role. So typically it's either Remdesivir or dexamethasone and no other treatment nothing else additionally. Less than 12-year-old, since it's not FDA approved, we usually have to discuss with the parents. We give them a handout saying, we can use this drug, we think it might help, but there is also the things that we have to monitor, like liver dysfunction and all of that, so we'll have to keep monitoring. Some parents have electively said, you know what, if this is not a drug that's tested, we don't want to try it, and we don't push it because there is no data to support it. So less than 12-year-olds, we usually ask the parents' consent. It doesn't have to be written, it's just like verbal consent. But about 12-year-olds, yes, if it is indicated, then we would use it. With regards to flu season, that's an excellent question. So we have had an amazingly quiet flu season, and that's very awesome because it means that all the mitigation strategies for COVID-19, mask wearing, social distancing, they really work even for influenza. And some people are also thinking, should we do this mask wearing just like in some of the Asian countries where they wear masks in flu season? Should we do that going forward? Personally, I might choose to do that next season in the flu season, whether it's mandated by the hospital or by the community or not, because I don't want to become sick. We know that adults and children die from influenza. Having said that, some of the influenza-related deaths have also been that data also came out recently, where in this last flu season in the US, we only had one pediatric death from influenza, and compared to prior seasons where upward of 200 to 300 kids have died because of influenza. And of course, the adult data is different as well. But across the board, we have not seen much influenza at all. Did you see cases with typical cytokine storm in children like adults? Actually, our experience here in my hospital, no, we did not have any of our COVID-19 kids present with cytokine storm. I think bigger hospitals, bigger centers where they have had more experience have seen cytokine storm in kids. Again, not as much as in adults.
There was a question earlier, Dr. Padhye, about the race discrepancy among Hispanics and Black people. Is that due to social economy? Is that genes, race, underlying conditions, crowded, households?
Yeah, I think it's all interlinked, right? The healthcare disparities and the outcome of that is all interlinked for our Black and Hispanic population. One leads to another, and so all the factors that you mentioned probably make a difference, and they're all interlinked.
Okay, we'll take a couple more questions. We try to conclude by 1:25.
My question for anyone have you seen MISC cases in your centers, or are they very sporadic? Or do you expect to see if your cases of COVID-19 are uptrending, at least based on I don't know if that Financial Times graph from before accurately reflects what's going on there. So let me go back to that. So I'll let you all weigh in on what you have seen. So at least this suggests that number of cases in Iraq are rising, but is that what you're seeing on the ground level?
I can answer on their behalf. No one trusts these numbers.
Yeah, okay. So do you think that they are more than, and that's a difficult question to answer, sorry.
Yeah, typically what is reported officially by the government is just like the tip of a huge iceberg. So people first, they do not go to seek help when they need it. And when they go and do the tests, there's a very sophisticated system of reporting, which is far away from being professional. This is what I've been following. The crowd, some have any other idea, let us know. But yeah,
One question, sorry.
Yeah, I think the numbers are
not.
It's
okay, go ahead, Dr. Padhye.
No, I was going to answer a different question, so I'll wait to answer before.
Yeah, the question about the truth of numbers reported from Iraq. I doubt that you guys trust these numbers. Do you?
The problem, the system looks weak in this issue, and I think this is the possibility of that misleading even for the doctors to see what's going on. Dr. Padhye, she asked about the MIS-C. I think very difficult to say this, whether it is presented or not, because there's a lot of shortage of the resources to go for the real diagnosis what's going on. I think there's many doctors, they are specialists in pediatric, and they are complaining about a lot of issues, especially for the pediatric.
Aslam, can you ask one of our pediatric colleagues to step in and talk about their experience? Like they can unmute themselves.
I think there is a well-expert pediatrician here with us. I think they can, if they can raise their hands, or you can unmute all and let them to choose whether they can mute or
raise their hands too if they want. I allowed the unmute button.
Okay, great.
So anyone among pediatrics colleagues who want to just say a few words about the Iraqi experience with COVID-19 in children would be highly appreciated. Okay, while waiting for someone to jump in, I have one more question for you, Dr. Padhye. We know some people with COVID in adults, they suffer from the post-COVID syndrome or the COVID hauler. Do you see similar experience in children?
Yes, again, very good question. We were seeing patients referred to us for non-specific symptoms after COVID, where they're tired a lot. They complain of intermittent fevers, but probably not like MISC type fevers, just fatigue in headaches, etc., abdominal pain, etc. So when typically in these patients, we would of course make sure that they don't have MISC, but these patients are those whose inflammation markers are also completely normal. So I've had a few patients like that. And then recently, from the UK, they just released some of their data as well, more literature on long COVID in children. So when the initial reports came in adults, there was really nothing about post-COVID, long COVID in children. And now that information is also flowing out. I don't have all the details of that study, but again, to know that those symptoms can linger along for months together. But again, it's important to think about what else could be going on with this child and not just long COVID. So getting a good thorough history, maybe some basic labs to make sure we're not missing anything before attributing it to long COVID. A question came up about Anakindra use. So yes, we have been using Anakindra here in some of our patients. It's an interleukin-1 receptor antagonist, and they prefer that because it has a short half-life. Yes, it does increase your risk for infections. It's a drug that's approved for rheumatoid arthritis in adults, but has been used by pediatric rheumatologists for other autoinflammatory conditions. So we use it under guidance of our rheumatologist, who decides what dose to use, when to escalate the dosing, when to go down on the dosing. Of course, it's a subcutaneous injection. And so, typically, but most from what I've seen, our rheumatologists do is they follow them closely, they taper the dose, they taper their steroids, and these kids kind of come off their immunomodulation in about a month or so, roughly.
Thank you, Dr. Padhye. I think if anyone wants a certificate, he can fill the form and he will get his certificate from the College of Medicine from the University of Anbar. Yeah, go ahead. Sorry, Dr. Mohammed.
Thanks so much. Yeah, I think we reached our 1.5 hour deadline. Anyone is willing to participate and talk about the Iraqi experience, I would like to end here and thank Dr. Padhye for her participation today and very informative presentation. Thank you all for joining us today, and hopefully we're going to see you soon and another webinar. Okay. Thank you all.
Absolutely. Thank you, everyone. Thank you, Dr. Alani.
Thank you.
Thank you, Dr. Padhye. It's our pleasure that you with us. Thank you for your time. Thank you, Dr. Mohammed, for your nice, really leading this meeting. So thank you all. Thank you all the attendees for your time. See you.